A little bit about myself. I always like to share. I think knowing where someone came from, it gives a lot of context of why they do what they do. I had pretty humble beginnings. Went to med school in northern India. Was had the opportunity to work in a very resource deficient environment, and I think that's definitely shaped how I think about a lot of the practices that we have, and when it comes to delivering healthcare. After I got back to the States, I did residency at UCLA, and then I worked as a hospitalist for a few years, for about 3 years, before matching into pulmonary critical care at Loma Linda University. Luckily, I had the opportunity to stay in California, and it wasn't until my pulmonary critical care fellowship where I became really interested in sleep. We, as a pulmonologist, we see a lot of patients who have a sleep issue called sleep apnea, and I was sort of fascinated by sleep as a field, and also discouraged by how broken the sleep healthcare space was. With that mindset, I had the privilege to do sleep medicine in Boston at Harvard, and that's where those guys opened my eyes about what sleep medicine actually is, circadian sciences, and my mindset shifted away from this idea of like OSA medicine or insomnia medicine to a much more comprehensive view of sleep medicine and how do we leverage sleep to have breakthroughs, whether that's in athletic performance or cognitive performance or creativity, and many of the things that sleep does serve us in. This is a very powerful quote that many of you may be already aware of, and I'll just read it out loud. If sleep does not serve an absolutely vital function, then it's the biggest mistake the evolutionary process has ever made. And if we think about that, evolution does not make mistakes. And if we've evolved to sleep in, at least for adults, 7 to 9 hour periods in a consolidated fashion, it must serve a very strong biologic reason. And if we deprive ourselves of doing that, then we just start wondering what are the downstream consequences of that. A lot of the learning of sleep deprivation that we have is from folks who have a disorder of sleep, like obstructive sleep apnea or insomnia or self-inflicted sleep deprivation. And a lot of the learnings of the consequences of the lack of sleep come from those cohorts. And we know that the lack of sleep deprivation leads to a whole bunch of downstream consequences, cardiovascular, neurologic, and we'll talk about some of those in just a few minutes. For the crowd here, please feel free to chime in. We have a new name here, Niema Nodum. What do you guys see here?
What do we
see a car. Yeah.
Oh, see.
What do you see?
Power.
Power. Oh, yeah, absolutely. You have the awareness that this is not just a parked car, but rather it's a car that is charging. It's receiving power right now. And I love this metaphor because there's a very powerful distinction between sleeping and resting. Resting being like a parked car, and sleeping being like a charging car. And if I told you that if this process of charging was being interrupted numerous times an hour, you can only start imagining what would happen to the battery life of this vehicle. But in addition to that, what's happening is if I said, imagine if during this process of charging, this vehicle was getting a new layer of rubber over its wheels. Somebody was coming out on the outside and cleaning it. Somebody was vacuuming it. Somebody was topping off the windshield wiper fluid. Somebody was changing out some other mechanical oils or something. And when we sleep, we're not just charging, but there's a whole host of physiologic processes that are happening. The processes that we have during daytime, during the biologic day, they switch from processes of the biologic day to the processes of biologic night. And that is in the digestive state, that happens in the gut, that happens in the muscles, that happens in the endocrine system. For example, growth hormone is circadian, and it only rises during sleep. Whether it happens in the central nervous system, where only during sleep is the glymphatic system filtered, and products like beta amyloid, which are precursors to Alzheimer's disease, are those filtered during sleep. Our immune system regenerates itself during sleep. So during sleep, a whole host of very important physiologic processes are happening. And if somebody does not get the opportunity to sleep, because of some kind of a sleep disturbance or sleep disorder, then one can start imagining and understanding why so many downstream consequences, why people develop so many downstream consequences because of sleep disorders, whether that's cardiovascular, neurologic, digestive, endocrine, and many more downstream. So this is an example of my children when they're sleeping. So when they're sleeping, there's a physiologic process that's happening, and it's not just a process of resting. So the topics today that I want to cover is how to screen patients for sleep apnea. And this could be in a primary care setting, this could be in a dental setting. Screening for sleep is one of these processes that we all have that is tangentially related to all specialties, whether it's a diabetic in an endocrine clinic, or someone with hypotestosterone in an endocrine clinic, or somebody who has AFib, heart failure in a cardiology clinic, or a patient who has dementia in a neurology clinic. So we should be screening for these patients in all specialties. I'll talk a little bit about why screening for these patients is so critical. We'll discuss some of the few treatment options. And lastly, I'll talk a little bit about when to refer to a sleep specialist. Many of us who are in the medical field and the dental field, we've heard of this acronym called STOP-BANG. This originates from the anesthesia literature of screening for sleep apnea in patients who were pre-op. And it's sort of been applied to multiple specialties thereafter. And it seems to be a reasonable tool to screen if somebody has obstructive sleep apnea. In a primary care setting, the internist or the family medicine doctor, they typically have so many other things to do that it's hard to ask some of these questions or dig through the chart to go through them. But if one does take the time to do that, if somebody has 3 of these 8 characteristics: snoring, tiredness, observed pauses in breathing. Sorry, this is a typo here. Blood pressure, a body mass index over 35, age over 50, neck circumference over 16, which is a large size, and a gender being male. If they screen positive for any of these 3 things, the likelihood of having sleep apnea is substantially elevated. And if they have severe sleep apnea, it's almost 100% sensitive. Given that this is an old questionnaire, even in larger studies, 25, 26,000 individuals, if somebody scores 3 of these 8 characteristics, the likelihood of this being sensitive to find some degree of sleep apnea is north of 90%. And you can see, like, the higher number of these characteristics, the higher the score, the higher the probability of detecting sleep apnea. And more so, it's more specific for moderate to severe sleep apnea as compared to mild sleep apnea. The other way to start thinking about this, traditionally in medicine, we've been taught to do it this way. But the other way to think about this is, as clinicians, we become very good at making observations. Like the second, if we see somebody walking into our clinic, we can start making observations about how are they walking, and then look for specific problems. And for sleep, the things that I have come across that have made it much easier to identify these patients is, the first thing is, like, is this person appearing overweight, or are they short of breath at rest? If someone's short of breath at rest and they're overweight, the likelihood of sleep apnea goes up. Are they a mouth breather or a nasal breather? This is quite underrated, but I wanted to share a picture here. This is looking at flow in 3 different scenarios. Image A is someone who has a closed mouth and is breathing through their nose, and it's checking velocity of airflow. Image B is someone who has an open mouth, but they're breathing through their nose. And image C is someone who's breathing through an open mouth. And what you can see, one of the pathophysiologic mechanisms in sleep apnea is the Stirling resistor model, where upstream flow and the collapsibility of midstream flow and downstream flow, they play a role in how airway tissues collapse. And what you can see here is that when someone is breathing through their nose, there is a less likelihood of collapsibility of the posterior pharynx as compared to somebody if they are a mouth breather. So people who are mouth breathers are at a much higher risk of developing upper airway collapse as compared to people who are nose breathers. And this is why this idea of lip taping retraining the muscles to breathe through their nose has become very popular and potentially effective for individuals. So just, looking at someone in clinic and while talking to them, are they a mouth breather or a nasal breather, can give a lot of clues to if this person's if they have a higher risk of having sleep apnea. And then if somebody has a whole host of medical conditions, resistant hypertension, they're on 3 different medications, they have AFib, they have heart failure with reduced ejection fraction or heart failure with preserved EF, or if they have any other metabolic diseases, fatty liver, diabetes, then the likelihood of having sleep apnea goes up. And I'll share with you why. To recap, when somebody has an obstructive event, a few physiologic things that happen. We have a few parameters across time. We have airflow, O2 saturation, systemic and pulmonary blood pressure, sympathetic nervous activity, and EEG brain activity. And you can see that whenever there's an obstructive event, there's a complete cessation of airflow. During that time of complete cessation of airflow, there is desaturations that are happening. During these desaturations, there is hypoxic vasoconstriction happening in the pulmonary vascular system, and there is sympathetic nervous system activity and an arousal that happens. And as a result of this, there is a rise in systemic blood pressure. A person has an arousal, they wake up, there's motor activity sent back to the airway, there is resumption of airflow, and again, there's an obstructive event. So when someone is going through these cycles and they're having intermittent hypoxia, they're having wide swings in blood pressure, both pulmonary and systemic, and there's persistent sympathetic nervous system overactivity and sleep fragmentation, that leads to this downstream consequence of oxidative stress, a pro-inflammatory state, endothelial dysfunction, and a whole host in different circulating factors, whether it's interleukins or tumor necrosis factors that are all pro-inflammatory. And as a result of that, you have all of these downstream consequences that start making more sense of metabolic disease, developing a stroke, at higher risk of having depression. Cardiovascular disease is probably the most well described. Neurodegenerative diseases start happening, and systemic hypertension. Cancer is kind of out there. The data is it is suggestive, but it's still something to be more evaluated. So whenever there is sleep disruption, based off of the previous image, you can start seeing how all of these downstream consequences can start happening. Catecholamine levels are going to be higher, cortisol levels are going to be higher. There's going to be circadian rhythm disruption. One of the things that happens with sleep disruption, and for those of us who have done shift work, whether on a night float duty in residency or fellowship, or pulling an all-nighter as in medical school or dental school, there is a substantial reduction in insulin sensitivity that happens from sleep disruption. And because of that, the hormones of satiety and appetite, those are changed, leptin and ghrelin. Leptin levels go down, ghrelin levels go up. There's an increased desire for carbohydrate-rich meals, appetite levels go up. So it sort of pushes people into the pathway of making poorer food choices. With apneic events, there's increased oxygen consumption, CO2 production, and sleep is supposed to be rest and restoration. So if there's increased oxygen consumption at that time, you can start seeing what are some of the downstream consequences. There's upregulation of these tumor necrosis factors, pro-inflammatory cytokines, and there's a reduction in melatonin production. And because of that, we have both short-term and long-term consequences. Long-term being the diabetes, hypertension, obesity side of things, and the short-term being a lot of things that we probably have experienced from sleep deprivation, whether it's a new mother who just has a newborn and stress levels, the tolerance for stress has changed, or there's somatic problems or psychosocial issues, to more chronic long-term consequences, such as the cardiovascular diseases and the metabolic disorders like diabetes. This is a really interesting slide for those of you who are in the internal medicine field, as well as the dental, but this makes it way more compelling to start screening for these problems, because so many of the visits in a primary care doctor's office are because of cardiovascular disorders. So during sleep apnea, you have this intermittent hypoxia, reoxygenation. You can have higher levels of carbon dioxide. You have autonomic dysfunction from the sympathetic nervous system overactivity. You have numerous arousals of sleep. During these apneic events, when breathing against a closed glottis, that's going to result in a whole host of change in intrathoracic pressures, more negative intrathoracic pressure than there should be one of the reasons why people who have sleep apnea also have reflux disease. And these patients, because of the apneic events that they're happening and the intermittent hypoxia, they're going to be at a high risk of having hypercapnia. This whole host of different mechanisms are resulting in these downstream consequences with inflammation, atherosclerosis, endothelial dysfunction, hypercoagulability, metabolic dysregulation. There's going to be hemodynamic changes because of changes in intrathoracic pressure. These changes in intrathoracic pressure over time, along with hypertension, can result in left atrial enlargement and sympathetic nervous system activation. All of these things combined result in a whole host of downstream cardiovascular problems, such as hypertension, AFib, and other arrhythmias, heart failure, coronary artery disease, ischemic or hemorrhagic strokes, pulmonary hypertension, metabolic syndrome, insulin resistance, and diabetes, and putting these people at a much higher mortality risk as compared to somebody who does not have sleep apnea. Just a few high-level highlights on the relationship of sleep apnea and cardiovascular diseases. In a cardiology clinic, the prevalence of sleep apnea is anywhere between 40 to 60%. I don't have a picture of this, but there's almost a dose-dependent relationship between hypertension and sleep apnea. The more resistant the hypertension, the higher the risk of sleep apnea, and many times people who have worsening of sleep apnea have a more likelihood of having hypertension. Almost 40% of patients with hypertension have some degree of sleep disorder breathing, and almost 70% of patients who have sleep apnea, 71% of people who have resistant hypertension have obstructive sleep apnea in those cohorts. And we know that if we treat the sleep apnea, the resistance of that hypertension goes down. So if somebody's on 3 or 4 medications for hypertension, it's extremely, extremely prudent that we address the sleep apnea if we're looking for the best outcomes for these patients. If somebody has, for example, heart failure, the prevalence of sleep apnea in the heart failure, whether preserved EF or reduced EF population, is somewhere between 50 to 70%, depending on which cohort you look at. And the prevalence of central sleep apnea in that population is about 2/3. And people who have heart failure, the whole goal is to reduce the sympathetic burden, reduce the pro-inflammatory state, ventricular ectopy, and improve LV function. So when we treat sleep apnea, we are driving that patient into reducing the sympathetic burden, reducing the pro-inflammatory state, and putting them at a lower risk of having other arrhythmias. For example, in the AFib population, the prevalence of sleep apnea is almost 35%. And this has been shown in multiple prospective trials that if sleep apnea is treated in this population, there is a reduction in recurrence, and there is a higher likelihood of rhythm control and a less likelihood of developing a recurrence of AFib requiring cardioversion, whether electrical or chemical, afterwards. The Orbit AF study basically documented that people who have AFib and sleep apnea, there was an increased risk of recurrence and an increased likelihood. If you treated the sleep apnea, there was an increased likelihood of rhythm control in that population, suggesting that it needs to be treated. If we don't treat sleep apnea post-ablation, in the AFib population, there's an almost 60% increased risk of recurrence in that population as compared to those who have had sleep apnea that's been treated. So many times we see a lot of patients who are getting a sleep test because they are in the process of undergoing a cardioversion or an ablation, and the cardiologist wants to make sure that the sleep apnea is well controlled before they proceed with any kind of cardiac procedures. The relationship of sleep apnea and metabolic disease is also very well defined, mostly stemming from insulin resistance. And if you look at this cohort of people who have 8,000 people who have obstructive sleep apnea, 12% of them will likely develop diabetes over a 67-month period. So just over 5 years, 10 to 12% of them will end up developing diabetes. In the context of severe sleep apnea, if somebody has severe sleep apnea, in that cohort, there is a higher risk of developing diabetes as compared to those who have mild sleep apnea. So that sort of suggests that the more significant the sleep apnea, the higher the likelihood of developing these downstream consequences. The relationship of sleep apnea and stroke is also very clear. People who have sleep apnea are at anywhere between a 3 to 6x increased risk of developing stroke as compared to patients who don't have sleep apnea. And people who have had a stroke, and those of us who have worked in the inpatient setting, those patients will have almost a 71% prevalence of sleep apnea, either obstructive or central, across a time period. So indicate, and also if we treat them, we believe that their mortality, functional, and cognitive outcomes will be better. So what are some of the different treatment options for people who do have obstructive sleep apnea? You know, many of you are familiar with this. Depending on burden of disease, burden of hypoxia, architecture of sleep, how symptomatic one is, one can come up with a very personalized way of delivering this care, but in a very broad framework. First line therapy for people who have any spectrum of sleep apnea is usually CPAP. CPAP works by sending a steady stream of air pressure to keep the airway open. It sort of acts as a pneumatic stent. Other devices that are available to patients are these dental appliances. They act mostly in the form of mandibular advancement. And by doing so, they create more space in the oropharynx and nasopharynx to allow more airflow during sleep and less collapse. There are also other novel therapies that are available, such as in INAP. INAP, where it's an intermittent negative airway pressure device. This is a suction canister. Instead of pushing air in, it sucks air out. And by doing so, you can pull the tongue forward to create more space in the back of the throat. And you've probably seen ads for this online. Many of these ads are quite comical, and these guys have done a wonderful job at the branding of what they're putting together. But the Inspire is an implantable device. It's sort of like a pacemaker for the tongue. It senses what's happening in the intercostal muscles, so it can sense breathing. And then it also senses what's happening to the tongue movement. And based off of inspiration and sort of posterior collapse of the tongue, it can stimulate the tongue during inspiration so that there is no obstruction of the upper airway. And this is FDA approved, and we've seen success with this as well. There's a whole host of second line options too. Excite OSA can be used as a first line option in people who have mild sleep apnea or snoring. But again, the idea is to stabilize the tongue during sleep. It sends an electrical impulse to the tongue. You use it for 20 minutes twice a day for about 6 weeks. And it's supposed to be like a electrical tongue stimulation device that strengthens a muscle and therefore preventing the tongue from collapsing posteriorly during sleep. And then thirdly, you know, there's a whole host of other surgical options, whether it's a UPPP or an MMA, that changes the anatomical architecture of someone's airway. And thereby, if the airway shape is different, then collapsibility of the airway will be different, and thereby addressing sleep apnea. And lastly, I just want to talk about when can one refer to a sleep specialist? And, you know, if somebody has poor sleep quality, or if you are concerned that the health of their sleep is poor, you can refer them to a sleep specialist. If you feel that someone is persistent, like you've started a therapy, but the patient is not necessarily benefiting from that therapy, they have sleep apnea, you started them on CPAP, and they still have persistent sleepiness, they don't sleep well during the night, or if you have someone who has insomnia, you've started them on a medication and they still can't sleep well, or they have daytime fatigue or sleepiness, these are patients who should be be referred to a sleep specialist. If you just want the patient, they have all these whole host of comorbidities and you want them to get a sleep test, these patients should be seen by a sleep physician. If someone is trying to troubleshoot, you've ordered their dental appliance, or you've ordered their CPAP machine, and you're struggling and troubleshooting this therapeutic modality, you're not sure if it's working or not, you can refer these patients to a sleep specialist. Or if you're concerned for an additional sleep disorder, it's not uncommon, similar to how in internal medicine diseases tend to cluster, it's not uncommon for someone to have dyslipidemia, hypertension, diabetes. Similarly, if somebody has a sleep disorder like sleep apnea, almost 30% of them will have some degree of insomnia. And it's not uncommon for them to have some restless legs, or occasionally you'll have someone who has other parasomnias or central reasons for hypersomnia like narcolepsy or idiopathic hypersomnia. So if you're concerned for another sleep disorder, that would be a good reason to refer to a sleep specialist. And Sagar, I'm going to pass this on to you if you're here to share a little bit about Empower Sleep and how we're different. And whenever you let me know, I can go to the next slide.
Yeah, of course. No, thanks, Al. So as you can see here, so for some of us that might have gone through the sleep care process or referred to a sleep lab, understand how frustrating oftentimes this process can be, going from the PCP to a sleep doctor to a sleep lab back to a sleep doctor, and then going through this whole complex maze of the DME experience. And at the end of the day, there's not much of a transparent pricing. Patients are just not really put at the center. And it takes a lot of time with not always the best outcomes. And so, as we all know, this whole process can be quite frustrating. It can be broken, it can be fragmented. And so, as you go to the next slide here, what you'll see is, as we thought a bit more about the process, it was just, how can we put patients at the center, use data to make the best decisions, make it very personalized, and also ensure that we are actually changing patients' behaviors and ensuring positive outcomes. So everything has been around doing longitudinal sleep testing, which Sahil could talk about more in the Q&A if that does come up, in terms of how the care delivery model is different and unique. And then also making sure that we manage the end-to-end treatment under one umbrella, doing it as quickly as possible. So if you move over to the next slide here, as you can see, everything we do is around longitudinal sleep testing. And maybe, Sal, if you want to talk a bit more about just how this works quickly, and we could also move on to the Q&A from here as well. But this is just an example of a user that's gone through and has done, as you can see, over 30 days of sleep testing here.
Yeah, absolutely. So this is an example. So what you see on the left side here is the person's apnea. So let me take a step back. Historically, what's happened, as Sagar was mentioning, was this idea of a single night sleep test. And it's almost like taking care of somebody who has diabetes with just a hemoglobin A1C. But we know that there are these tools like continuous glucose monitors that exist. So we've redesigned the patient experience. So similar to how an endocrinologist can take care of someone who has a continuous glucose monitor in a fundamentally different way, because they understand how that person's metabolic profile is changing with foods and exercise and medications. Similarly, we can address someone's sleep with day-to-day sleep testing. And we built our platform on top of Sleep Image, which is a home sleep testing technology. And it allows patients to do a sleep test every single night using a wearable ring device. And it allows one to understand how their sleep is changing on a night-to-night basis using different interventions. Are they using a wedge? Are they using a side sleeping pillow? Are they taking a medication? How does it influence their sleep quality? How does it influence their apnea index? Is CPAP even working? We see patients here all the time where patients are on a CPAP device, although their apnea index gets better, but their sleep quality gets destroyed. So maybe that's not the right therapeutic modality for that individual, and they need a dental appliance or they need an INAP type of a device. So it really allows us to personalize their care plan. And just to give some context, we've been around for a little over a year now, and very quickly we've been able to be. If you Google sleep lab near me, many times you'll notice that they usually have very poor reviews and a lot of unhappy patients. But we've taken a lot of pride in delivering this personalized sleep care virtually to patients, and patients have been very kind and generous with all of the words and thoughts that they've shared. And using that feedback, we continue to iterate on the process and the product for them. In terms of our care team, as I mentioned earlier, we strive to deliver Harvard-grade sleep care online. And a lot of our advisors are based out of my fellowship program. And the idea is, how do we bring this amazing quality of care and deliver it into a very magical experience directed for the patient. The way that it works is, once we receive the referral, we typically reach out to the patient a few times in the first week to schedule their virtual visit. It's a comprehensive 1-hour consultation where we spend about 20 to 30 minutes really understanding their medical history. And we spend about 10-15 minutes based off of their chief complaint, sharing some educational content on some tips and tricks that they can walk away from. After that, they'll do a multi-night home sleep test. It's somewhere between 7 to 10 nights of testing. And on a follow-up visit 2 weeks after, we will review those results with them virtually. If they need any kind of therapy, like a CPAP machine, we'll order it and it'll be delivered to their home, and we'll continue to take care of them longitudinally. Or if they don't want to try CPAP and they're a good candidate for a dental appliance based off of their history, sleep apnea burden, then we'll refer them to a dentist that we work with who is in their zip code, and we'll refer the patient and try to schedule their appointment for them so that there's a warm handoff to a dentist, and the dentist can evaluate them for any dental solution. We try to do this all within a couple of weeks, but the patients are typically seen within a week, tested a few days thereafter, and a follow-up visit usually from a few days thereafter that, after they've done a decent number of data, a decent number of testing nights. Yeah, and the device is a little ring device. It's not as aesthetic as the Aura ring. It looks like an oximeter that's Bluetooth enabled, so all the data goes through the phone to the cloud where the clinician can review it. Yeah, we actually just submitted when we just present. I'll send you a picture of our abstract. We
Okay.
just presented an abstract at like a week ago at this year's annual American Academy of Sleep Medicine, sharing that we've taken care of over 1,000 patients. There's over 10,000 hours of data that we've collected on longitudinal testing, and how it's allowed us to really personalize their care plan, as well as understand what happens to someone's sleep over time using different modalities. Consumer grade devices have done a wonderful job at driving awareness of the importance of sleep, as well as helping patients understand if there is actually something wrong with their sleep. So they do a wonderful job at driving awareness. When it comes to like a diagnostic test, then in those situations, like the values that we get from hypoxia burden, or the values that we get on what's called like this apnea hypopnea index or oxygen desaturation index, these parameters that we look at when we're looking at patients who have sleep apnea, it doesn't really give us that information that allows us to be confident in prescribing them something. The other thing is the data from an Aura ring is not something that the insurance will see as a FDA approved report for any clinician to prescribe a CPAP and have the insurance pay for it. So these devices are very good for driving awareness, but I would not use them as a diagnostic test. I just saw a patient last week who her Garmin was telling her that her oxygen levels dropped down to the 80s, and she was concerned for sleep apnea. And we did almost 15 nights of testing for her, and she doesn't have any substantial hypoxia. And this was across numerous nights. Just allowed us to reassure her that your breathing is fine, and I wouldn't do anything necessarily about it. So these devices are good, but I would still do a medical grade home sleep test to be certain that everything is okay. And also, it gives us the ability to prescribe something if that's what the patient needs.
I'll jump in if I may on the technical parameters. I think what's important to diagnose sleep apnea and many other sleep breathing conditions is the oxygenation level of blood, so hypoxia, that Sahil has mentioned. And quite comparing side by side, look at technical parameters. Our ring doesn't measure it as frequently as the sleep image sensor does. So your image sensor does it every second, which is actually by definition something is necessary in order to determine stops in breathing and reduction in breathing. So that's, for me, this is the main distinction. Our ring and many other wellness sensors, they just don't pay as much attention, and they don't measure the blood oxygenation as frequently, which results in less precise ability, less accuracy detecting stops in breathing and reduction in breathing.
Yeah, totally. And it also kills the battery life. Like, these devices are not designed for they're designed for longevity, in the sense of like the longer battery life, so the consumer doesn't need to charge them on a daily basis. And that's one of the other reasons that I've learned that these consumer grade devices, they don't sample as frequently. Yeah, to improve sleep quality, there's a lot of if we think about it from like an evolutionary process, humans are it's supposed to be effortless to fall asleep. It's like breathing, right? Like, we don't have to think about breathing. Sleep is supposed to be the function of sleep is supposed to be similar to that. We should not have to think about sleeping, nor should it be difficult to fall asleep. And when it comes to then like these lifestyle practices that make it difficult to fall asleep, the way to think about it is like, what are the behaviors that we're doing that are conducive to wakefulness at the time of when we are sleeping? Having extra light in the room in the hours of darkness is light is conducive to wakefulness. So dimming the lights in the evening hours is important. Making sure that there is the abstinence of caffeine at least 6 to 8 hours before habitual sleep time. Making sure that the timing of sleep and wake is habitual. It's maybe a flux of about an hour. Making sure that there's some kind of a wind down routine that is anywhere between 30 minutes to 1.5 hours before sleep, that is free of screen time or any wake promoting activity, whether that's television, phone, doing things like reading a book, reading a magazine, doing some stretching exercises, yoga in the evening hours before bed, breathing exercises. They can change how our autonomic nervous system is behaving. When we start replacing things like a lot of light, a late meal, evening caffeine, alcohol, and with dinner, with things that are conducive to sleep, it becomes substantially, and if done habitually, it becomes substantially easier for people to fall asleep and have a better quality of sleep. If somebody has like a sleep disorder, then it may not necessarily, that needs to be addressed head on and directly, like if they have insomnia or restless legs or sleep apnea. But these are some like very easy low hanging fruit that anybody can do to just improve the overall quality of their sleep. Circadian refers to anything that has a peak or a trough across a 24-hour period. So everything that we do is circadian. Our breathing is the volume of breath that we take is circadian. Like if we do a pulmonary function test in the morning hour versus the nighttime hour, you're going to get different values because there is a circadian nature to that. During the hours of darkness, evening hours, assuming someone is sleeping, blood pressure dipping happens, stroke volume in our heart drops down. So our digestion slows down during hours of darkness. Melatonin levels are only elevated during hours of darkness. So circadian basically refers to, across this 24-hour period, what is the peak and trough of that physiologic process. Sleep happens to be one of those physiologic processes. Sleep is an output of sort of this idea of like level of awareness, ranging from super aware to being asleep. So sleeping during the biologic night is different from sleeping during the biologic day. If someone sleeps during their biologic day, their quality of sleep won't be as good as compared to sleeping during their biologic night. So this idea of circadian science is very, very broad, and it's tangentially related to all specialties. Sleeping, it happens to be an output of the circadian system, and that's why it gets bundled into sleep medicine as a field. And then OSA medicine is even a smaller part of sleep medicine. It's just looking at breathing during sleep, where there are these obstructive events that are happening. Yeah, no, that's a good question. So usually one wants to address whatever appears to be the elephant in the room. So for example, if someone has symptoms of insomnia and they also have symptoms of sleep apnea, if their symptoms of sleep apnea are the predominant symptom and the sleep test shows that also, I will typically target the sleep apnea first and then address the insomnia thereafter. But then sometimes you see patients who have some degree of mild sleep apnea, but insomnia is the bigger problem here. And in those situations, I'll address the insomnia first, and then the sleep apnea thereafter. It just requires getting a good history and looking at the sleep test with a different eye. But whatever is the predominant problem, the goal is trying to address that first before the other one. Home sleep tests do a very good job at delineating obstructive versus central. That's very clear. And because one is looking at the raw data as well, it's hard to miss central sleep apnea if somebody does have it. And so like the history plus 7 to 10 nights of data collection, if somebody has central sleep apnea, we should be able to figure that out. Like something is wrong on our end if we're not able to do that.